All right. So everyone, welcome to 390. We're officially back in the med school now. So to kick off the season for us is Katie Bukiri. I met Katie back when we were Heinz Gen Med, Heinz Gen Med 5, and she's graciously returned to give us a lecture on psychiatric emergencies. So Katie, thank you very much.
Check. Okay. Been so nervous about this thing. Okay, so hi, I'm Katie. I'm a fourth-year psychiatry resident here at Loyola. What I'm going to talk to you guys about today is the management of psychiatric emergencies, some safety things to take into consideration if you're dealing with an aggressive patient or someone who might be agitated, and then how to determine decision-making capacity. So, okay, wait, no, I got it. Okay, my disclosures. I'm friends with Peter Babinski. So if there's complaints about this lecture, send it over to him. I wanted to make it a little bit better, but he told me I couldn't. Okay, so overview of what we're going to be talking about today. And if at any point you guys have a question, you can just yell out or say something. So we're going to go through what's a psychiatric emergency, agitation management, because that's one of the more acute things you're going to be seeing, suicide risk assessment, and then how to assess a patient for decision-making capacity. Thanks. Just click minimize. All right. So what's a psychiatric emergency? I know when people have medical emergencies that you guys deal with, it's something that could be life-threatening or catastrophic. With psychiatry, the way that they define it with the APA, the American Psychiatric Association, is an acute disturbance of thought, affect, psychomotor activity, leading to a threat to the patient or others in the environment. So you need to take a look at what conditions cause this alteration in behavior, emotion, and thought presenting acutely, and what's a need for immediate attention for care. So the common psychiatric emergencies we see is suicidal ideation or suicidal threat, agitation, violent, disruptive behavior, psychosis, which can lead to dangerous behavior and thoughts, mania, intoxication, anxiety, and panic. And then as for the other thing, you want to rule out any medical conditions that can present with psych symptoms. So as you can see, there's a lot. I know that pneumonia is spelled with a P. I don't know where that went, but under infections. But so yeah, you could have something going on in your central nervous system, like normal pressure, hydrocephalus, the wet, wacky, wobbly, electrolyte disturbances, autoimmune diseases, sepsis, anything that is going on medically, or any of these kind of things can alter someone's mental status. And then of course you want to just know about like alcohol, cocaine, marijuana, PCP, amphetamines, and then misuse of medications. So let's see. So agitation is defined as excessive motor or verbal activity. Aggression is the actual noxious behavior that can be verbal, physical against objects, or physical against people. And then violence denotes physical aggression by people against other people. So what are some aggressive behaviors patients can display? Sometimes if they're physically aggressive, they might throw things, grab objects, destroy items, fight with you. Verbally, they might be swearing at you, screaming. And then there's non-aggressive behaviors like restlessness, wandering, and then inappropriate behavior like disrobing, being intrusive or inappropriate with the interviewer, and then repetitive questioning. So why do we care about violence in healthcare? Healthcare causes 45% of non-fatal workplace assaults. The psychiatrists in the ED are at the highest risk. Physician homicides between 1981 to 2017, 39% psychiatrists, 16% PCPs, 13% OB-GYN. So you can kind of imagine with these providers, there could be emotionally charged situations or something adverse had happened and these patients are really aggravated and commit violence. So the best predictor of violence is a history of violence. The other thing too is when you have a violent patient, you really want to be on the lookout for substance use. 50% of people who commit homicides consumed alcohol prior to the act. And so there is a misconception that psychiatric illness makes patients more prone to being violent. In a study in 2014, it showed that severe mental illness victims are not perpetrators, but more likely to be the victims of violence. And then there's just a lot of stigma with a mental health diagnosis and violent acts. So, I mean, every time there's a school shooting, I feel like people look if the person was on an SSRI. So, or if they were listening to Marilyn Manson is another risk factor. So what are some common psych conditions you need to be aware of that could be associated with violence? So I think that a lot of people just jump to the schizophrenia conclusion when they hear about like a violent act. I know for a while, the FBI was profiling killers like organized or disorganized. And a lot of them, they were diagnosed as schizophrenic based on how they left the crime scene. So a low proportion of the patients become violent. And then in a study, only 16% of perpetrators had schizophrenia. And that's going to be more like your paranoid schizophrenia. Substance use and personality disorders. So antisocial personality disorder is a really big one. That's going to be a person who doesn't really have regard for violating the rights of others. And there's a very high comorbid substance use with that, particularly alcohol. So also something to look out for if a patient's displaying any kind of manipulative behavior, to just sort of think about maybe they have like a cluster B personality disorder. With dementia or delirium, you're going to have someone who is disinhibited, and they're also impulsive, so they can pose a threat to themselves as well as staff. Trauma history, witnessing violence, PTSD, and then any kind of brain injury or a frontal lobe impairment. So then, like I said before, the best way to assess the risk of violence is to see if there's a history of violence. You can usually, I mean, depending on the acuity of the situation, you might not be able to take like a legal history on a patient, but when you do have like a chance to talk to the patient, if they're calm, you can ask about like past arrests, past like ever been in trouble for domestic violence, stuff like that. And then the circumstances of violence and characteristics of people involved are important. Substance use and abuse carries a 30 times increased risk for violence compared to the general population. Okay, so why why do people want to act violently? And what are some behavioral predictors that say this might start getting like going beyond verbal threats to something more serious? So the motivation for patients acting violently is not well studied in the literature. A common consensus is there's a lot of fear, guilt, manipulation, intimidation, pain, medication side effects, and illness. And a lot of times this stems from the patient not feeling like they're being heard by the provider. No one's really listening to them. People might be dismissive of their story. So that can be really frustrating because they are not being validated. And then the predictors, angry words, so the person swearing at you, loud or abusive language, and then physical agitation, like making fists like Arthur, pacing, and akathisia or restlessness, an inner sense of restlessness. So now, how do we approach someone who's really agitated? So commonly these people they may be admitted to the medical floor and they need medical clearance before they can go to a psych ward. I'll talk about that a little bit later. But say you're admitting someone for like alcohol detox or opiate detox, the agitation and aggression is usually highest within the first 2 days of admission. With psychosis, you have patients who have delusions and can be paranoid or suspicious of providers. And then with substance use, they're going through withdrawal, which is uncomfortable. And then they're just irritated. They don't want to be there. Frontal lobe impairment, poor impulse control, TBI, again, alcohol, drugs. PCP is a wild drug if you've ever seen anyone on it. I had a patient who was crawling around the emergency room and said like ghosts were chasing her. And then she was trying to leave and her uncle was trying to like get her out of there. And I'm like, she came in and was crawling around the emergency room. And he was like, side-eyed her and he's like, yeah, she got to go to inpatient. So, I mean, PCP is nuts. Like people get superhuman strength. Okay, so with the agitation, you want to determine like maybe what's the underlying thing to this aggression. So is the patient angry at staff? Is the patient confused? Are they delirious? Are they psychotic? Are they undergoing withdrawal? Typically, you would get the medical workup on these people. The UDS is important because a lot of times people won't admit to what they're taking. And that can kind of be used later when you have a conversation with the patient, if there's a positive result for something they didn't endorse. So if you're gonna be seeing a psychotic patient, recognize that they can be paranoid and you don't want to startle them. So approach from a line of sight. Don't yell or appear aggressive. And you want to watch, again, signs of agitation, the pacing, restlessness, raised voice, squeezing hand, and intense staring. Okay, so once you're paged, there's this patient who's throwing a fit. They want to leave AMA. In your page to go talk to the patient. If the patient if you get any inkling that there's a risk for danger or violence or any kind of harm, definitely trust your gut instinct with that. And you don't need to go in or be alone in the patient encounter. So with the patient, it's good to remove them from the chaos, take them to an isolated area. It's okay to leave the door open, like ajar. keep your distance. So typically, I mean, social distancing, we're all good at it now, typically like 6 feet between you and a patient. Sometimes with paranoid patients, you're gonna have to be even further just because they're so distrustful. When you approach them, don't seem aggressive or threatening. You want to keep your hands at your side. Don't make fists back, even though you might be tempted to. So stay between the patient and the door and don't be backed into the room. That's, you always want to be equidistant to the door, as the patient should be too. Keep your voice level calm, don't escalate. And then if you start building rapport early, this will be better because later you're going to be asking more sensitive questions that the patient might not want to disclose to a provider, like thoughts about killing themselves or other people, whether or not they have access to firearms, what drugs they're taking, if they're drinking. And listen to the patient and check in to let them know that you're understanding what they're saying. I think it's really important in these kind of situations, even if the person's like super irrational and you know logically you know that this person's very irrational, to let them tell their story, validate, like, okay, like I don't know, what's an example, like if people are following me, like that must feel really scary to have people following you. Like it's good to respond with a empathetic phrase, and you can kind of just address the feeling without necessarily playing into any delusional thought content or paranoia, psychosis, and just start to build that rapport. Other things, like depending on where you're seeing the patient, it could be the emergency room. If that's the case, you could ask if they're hungry, get them a sandwich, and that's an easy way to build rapport. Same thing with like water or something to drink. Then the other big one is cigarettes. I don't know what Loyola's policy is on that, but at Hines, you can give people permission to go smoke, and God bless them. All right. So again, kind of what just to send home the points on de-escalation. You want to speak calm, be polite, be direct, low volume. If the patient's saying stuff to you that's attacking or insulting, don't personalize it, because this person's not, they're very emotionally charged and not in the right frame of mind. So verbal attacks, arguing, machoism, and you can, you don't want to leave a patient like this alone, but if you are starting to feel threatened or uncomfortable, you could ask someone to serve as a one-to-one while you go get additional staff. You want to encourage the patient to identify the problem, provide choices, even if it's a choice, no choice, meaning that treatment's going to go one way, but the patient doesn't want it. I had a psychotic guy at Hines who said he killed 100 Marines and gave a fake name, was like there to see his psychiatrist who's over at Jesse Brown. And like he was completely disorganized. There was no way he wasn't going to go inpatient, but he was refusing it to myself and then my supervisor, Dr. Elvey. As soon as the security showed up and he saw like the people in uniforms, he just got up and went with them. So it's good to utilize your resources in those situations. And a lot of times patients will argue, but there is a lot of backup support. And again, even if the person's saying stuff that's completely ridiculous to you, just try to practice empathy and validation of feelings. And same thing, so if you have someone who's getting like physically worked up, you wanna make sure you check your surroundings, make sure there's not like IV poles the patient can throw or something that's in the room that the patient could hurt themselves with. Make eye contact without glaring or staring. Back away, open palms, supportive body language, and like angled instead of head-on positioning. So that's less confrontational. Okay, so I feel like this is the part that you guys probably care about the most. So what do you do if you have someone who's really agitated? First and foremost, you really do want to try to verbally redirect before you go and give them emergency meds. Psychiatric medications cannot be given to a patient against their will unless there's an emergency, meaning there's an imminent threat to the patient or others around them. With chemical sedation, you got your choice of a benzo plus or minus an antipsychotic. So Ativan is the go-to that we use. And then Haldol's the OG. That one's pretty good for agitation, delirium. But you need to be mindful when you use it because of the extrapyramidal symptoms. People can have a really quick and sensitive reaction to the medication. And those are treated with Benadryl or Cogentin. Of course, like the only part about the EKG we care about, so you got to make sure that QTC isn't prolonged, especially if you're giving IV Haldol. And then you don't want to use it with Parkinson's or Lewy body dementia, and that's because of the dopamine antagonism. Like someone's motor system is already going out the window and you just don't want to block it even more. Olanzapine, you could, so Haldol is IM, IV, or PO. That's nice because if you have someone agitated and you need to give meds emergently, PO is probably not going to be the route that you take. Olanzapine, so that one's IM or PO. You want to use 5 to 10 milligrams. And then you want to watch using IM olanzapine in conjunction with IM lorazepam. And that's because the two together can increase like cardiorespiratory depression. And there's not a lot of data on that, but it's just something that we go by. I think it was one of the drug trials when that data came out. And then last but not least, ziprasidone. You could do that one IM. You don't want to give more than 40 a day. And then black box warning about that QTC. Restraints. So you really don't want to use, restraint should be last effort, especially with a really agitated patient. It might be necessary in the case that you have a patient who's really like physically out of control and you can't, they're posing a threat, they're knocking stuff over, they're like just completely freaking out. It's usually best with that kind of thing to restrain the patient. They're going to yell and scream at you, but at least they're confined and they're not posing a threat to the people around them, and they themselves are safe. So normally restraints are a team decision, and a physician must write the order for it, and it needs to be renewed every 4 hours. You need to check, and you want to watch for stuff like elevated CK from being in the restraints for too long. And then the other thing with restraints is you can work with a patient. If you have someone in restraints and they're calmed down, they're cooperating with you now, you could always give them or like remove like one extremity at a time to see how they do with less and less. And if they're showing improved behavior, you can kind of assess if the person's, it's okay to take off the restraints. So, okay, the other big topic in like emergency psych is going to be suicide risk assessment. I feel like this stuff is taught pretty well in med school, so I won't go into all of the like little details. Excuse me, one second. But as physicians, you're going to see people with depression, with psychiatric issues, and you're going to come across people who are suicidal or have a positive PHQ-9, the depression screening. So what you want to do with that kind of patient is look for warning signs. So the biggest thing is, are they threatening to kill themselves? Are they looking for a way to kill themselves? Are they stockpiling pills? Are they trying to buy a gun? And then are they talking about death? I guess there's a myth that if someone talks about death, they're not really going to kill themselves, but that's not true. Or the person might be writing about death, dying, suicide. And then kind of the more acute things that you see with a patient who's suicidal, a sense of hopelessness, rage or anger, impulsivity, which is concerning because if they do have a plan, they might go through with it. Feeling trapped, like there's no way out, substance use, social withdrawal, anxiety, agitation, inability to sleep, sleeping all the time, no sense of purpose. So those are some of the more acute dynamic factors that you want to think about. I think that hopelessness, despair, and insomnia, if I have someone with those three symptoms, I'm pretty concerned about them actually going through with attempting suicide. So the risk factors, Caucasian elderly male over 65, widowed or divorced. Things you guys could look out for is if they have a newly diagnosed medical problem, if symptoms are worsening, and then pain is huge. So when patients are in pain, that's a really big risk factor for self-harm and suicide. Chronic illness, psych diagnoses, of course, depression is the most common. Does this person have access to weapons? Do they have a trauma history? Victims of physical, emotional, or sexual abuse are at higher risk of suicide. Loss, did they just lose their house, all their money? Did they break up with someone? And then again, too, medical illnesses can be physically limiting, which can cause a lot of frustration. And then the other thing too is the person who was recently discharged from an inpatient unit. And then protective factors are your social support, spirituality, sense of responsibility to the family, kids, reality testing, coping skills, positive therapeutic relationships. So I think that when you're talking to a patient about this kind of stuff, it's best to just use like very like straightforward language and not beat around the bush with what you're asking. I think that I know at least I was anxious about asking people about suicidal ideation when I was an intern. I felt like it was very intrusive, but now I'm like, are you going to kill yourself? I'm desensitized to it now. So what you want to do though is you do want to have a discussion with the patient. You want to be non-judgmental. You want to be empathetic, understand and validate before you ask more explicit questions. So again, like the hopelessness, have you ever had thoughts about taking your life? If yes, when? Do you have a plan? have you ever attempted? And then with that, you're gonna have to make a clinical decision. So say you're outpatient, you have someone just for like a general physical exam, they score positive on the PHQ-9. They're endorsing to you that, yeah, they've had suicidal thoughts. They have a plan to drink vodka and overdose on Tylenol. And they don't know what to do. They can't identify protective factors. That person, you're gonna call security or the EMS, and that person's gonna go to the ED for a psychiatric evaluation and then admission to a psych unit. Sometimes it's not so cut and dry or clear. And I think that you can use your relationship with the patient to make to influence your decision. And then you want to get collateral from this person's family, get someone else involved, make sure they have a safe place to go, increase contact, and then help them out with resources. A lot of people, there's a lot of barriers to care, obviously, and a lot of people are afraid to get mental health help because of the stigma. So this was one I just threw in this morning for you guys. Switching gears, another psych thing you guys might have is substance withdrawal. Again, I just wanted to go over quickly like what you do in the situation that you have a patient admitted. Alcohol, it's going to be the multivitamin, folate, thiamine, and then SIWA protocol, Ativan, and let them just detox. With opiates, same thing, it's cows. Clonidine for the autonomic dysregulation. You want to give basically just supportive care. The other thing too, I think Loyola and Suboxone now, they're offering Suboxone to patients. So that could, if someone's serious about like quitting or they want to start the Suboxone therapy, you can do that. You just need to do it while they're mid-withdrawal. Otherwise, it's not going to be a good time. So this is, I hate slides like this that are like obnoxious and just a big chart, but this is actually pretty good if you guys get copies of the slides. It's like a cheat sheet for different kinds of psychiatric conditions and what you can do. So it's nice because it has, let's just go through, like for agitation, you don't want to use the Haldol and Lewy body, Parkinson's, someone with QTC issues, you need to be careful about how it's being administered. Seroquel, that's a second generation antipsychotic that has less affinity for the D2 receptors with motor. So that one's generally okay to use in Lewy body dementia and Parkinson's, but again, you just want to be really careful because they all have the black box warning with use in the elderly. And then Ativan, that's something you wouldn't give for delirium. You want to give that to someone maybe who's agitated with liver disease. Ativan with delirium can be even more disinhibiting. And then do they get copies of this slide? Okay, so yeah, just if you have, you could just take a look at this. It's pretty good. And it helps you frame a way of thinking about the medications. Okay, last but not least, we got capacity versus competency. If you want to annoy a psych resident, call a consult and ask for if the patient is competent. People will get like irrationally mad, and then they'll want to be passive aggressive and school you on what competence is. But we're not going to let that happen, right? So capacity, this is the degree to which a patient is able to understand relevant information relevant to a treatment decision, appreciate the reasonably foreseeable consequences of a decision or lack of decision for proposed medical interventions. Capacity can be determined by any physician. You guys got the power to do it. So I'm going to teach you how, because a lot of times too in psych we get consults for capacity. Like this person doesn't want to get their Whipple, and I'm like, I don't, what am I going to talk to them about? But so in those kind of cases, I'll have like someone from the team come with me because I don't know all the nuances of a Whipple procedure as much as I like saying the name. And then, so you want to ask for, does your patient have decision-making capacity? And you want to make a specific decision or a specific thing that you're trying to tease out, because someone can lack capacity with one decision, but then also have capacity with another. So competence, that's a legal term. It regards the person's ability to participate in legal proceedings like standing trial. And these are determined by court-appointed experts. Okay, so capacity is really, decision-making capacity and evaluating it is really rooted in ethics and then informed consent. We want to follow the principle of autonomy and respect our patients and their informed decisions. And capable patients, by definition, are able to give informed consent to a treatment. So again, it's important for a non-autonomy benefits, non-maleficence. Generally, an informed patient is a good judge of what broad sort of treatment is in his or her best interest. In the law, capable patients entitled to make their own informed decisions. So if someone is incapable, the physician can obtain consent from a designated substitution decision maker. And this is on the presumption of capacity for adults. For minors, you need to check provincial legislation on mature minors, Child Welfare Act. So, okay, how do we get, or how do we tell if someone has decision-making capacity? So, like I said before, any physician can do this. The evaluation is a point in time assessment, meaning you're assessing the person's ability to make a decision at that point in time. It may be different later during their hospital course, or like what they express as something they want could change. So looking for consistency in what people say is something to definitely keep in mind with this. So it must be assessed in regards to specific treatment or procedure. And then there is no like universal decision-making capacity, that's competency. So the four accepted decision-making abilities that constitute capacity, first we have understanding, then appreciation, reasoning, and then expressing a choice. So with understanding, so the physician should ask the patient to describe views of the medical condition, proposed treatment, and likely outcome. So what is the patient's factual understanding? So do they understand their illness? Do they understand the prognosis? Do they understand risks and benefits of treatment or not getting treatment? So this is ways you could ask, tell me about your condition, tell me about the Whipple procedure. I'm going to just use that as a horrible example. Possible benefits from treatments, the risks or discomforts, any other possible treatments that might be available, risks and benefits to the treatments or procedures being offered, and the possible risks and benefits of no treatment at all. So the next component is appreciation and insight. Does the patient recognize that their well-being is affected by the outcome of the decision they're making right now? So do they appreciate if they'll benefit or suffer from the consequences of the decision? The patient needs to know how the decision is going to affect them. They need to be able to apply facts to their situation. They need to, you could ask what the diagnosis again means to them, and then what will this decision change? So they're able to think broadly and future oriented about what they're agreeing or not agreeing to. So yeah, and then another thing too you could say is, how does this condition affect your life? The example here being diabetes. So that's the second component. Third, we got reasoning, which is the patient should be realistic in their decision making, and they should use information logically to reach a decision. You want it when you're talking to the patient about this, you want to see if they can rationally manipulate information. So again, tell me how you reached the decision to accept or reject the recommended treatment. What were the factors that were important to you in reaching the decision? How do you balance those factors? Patients aren't required to agree with the physician's recommendations or proposed intervention. So some other things, if you're getting someone who might seem ambivalent or not sure about the effects of the decision they're making, you could ask them like what they really believe is wrong with their health. Do you think you need treatment? What treatment do you think would work best for you? What do you believe will happen if you're not treated? And why did the doctor recommend this? And then last is expressing a choice. This is where that consistency is really important, because with decision-making capacity, ideally they're going to be making a consistent decision. So it's not changing. It can be really confusing when it flip-flops. So you need to have the evidence of a choice or preference. The patient needs to be able to express a consistent preference or decision for or against something. So if a person's unable to or unwilling to express preference, they presumably lack capacity to make a choice. So say you're doing a capacity evaluation on someone and they tell you to like get the F out of their room. You can't, they lack capacity at that point, because you can't argue for it. They're not willing to participate in the conversation. So, yeah, the evidence of a choice, you can repeatedly ask that. You don't need to do a formal capacity evaluation every time. You just want to see the stability of the choice and if it's consistent with what their goals and ideas are. Okay, so you do want to be careful with conditions that can diminish or impair decision-making capacities. So there's psychological factors and there's also cognitive biases, downplaying risk, optimistic framing of problems, blindness to the effect of one's decision, and poor problem-solving skills. I think that this is actually pretty relevant right now, considering there's a lot of unvaccinated people, and I think that there's a lot of misinformation. Other things, psych diagnoses. So schizophrenia is a tricky one. People with a psych condition can have decision-making capacity, even if they're exhibiting like active symptoms. Neurocognitive disorders, so like Alzheimer's, Parkinson's, anything that's going to impair cognition. Other things like, did the patient recently have anesthesia? Are they delirious? And are they intoxicated? And then just because someone's alert and oriented, and that doesn't mean always mean they have capacity. And then the mini mental status exam isn't predictive of decision-making capacity. And then this is what you can write in your note to cover your bases with your capacity evaluation. You can just copy paste this if you want into your templates. But so essentially you're saying that you went through all the facets of determining capacity, and this is what your findings were. So what if a patient lacks capacity or they don't have capacity to make a decision? If there's an emergency situation, you can do life-saving interventions without consent, despite patient objections. You can also find the surrogate decision maker or power of attorney. So that's going to be the POA, then the spouse. So there's a kind of a pecking order as to who can make the decisions. And even before you speak to a POA, like I said in the first point, you can provide treatment against the patient's wishes only if they're at imminent risk for harm. So diabetes or septic shock, DKA, not DKA or septic shock. And then if a patient lacks capacity, they don't need to be certified for inpatient admission. So a lot of times people will call psych because someone wants to leave AMA, but they lack capacity. And they'll ask us to put the certificate in the chart saying that the patient can't leave. We can't do that. So what if a person lacks capacity and they're trying to leave AMA? So psychiatry doesn't hold patients against their will for medical treatment. It's nice to say that because psychiatry has a really shady past. And then patients can be held if medically the illness is life-threatening and they don't have capacity. And that's up to you guys, the medicine team and the providers, to determine what's life-threatening. And then the certificate. So the certificate's a legal document or certifying someone for inpatient involuntary admission to a psych facility requires two legal documents. One is a petition that can be filled out by anyone. So commonly in the hospital, it's nurses or social workers. And then a certificate which any physician can write and sign. So you guys have the power to involuntarily send people to Madden. Use it wisely. So why do we certify? If someone's suicidal, homicidal, likely to hurt someone because of their mental health condition, they can't tend to their basic needs. So they pose a threat to themselves or possibly others in that regard. Again, someone lacks capacity, we don't want to send them to Madden. So we don't do the cert. And then say you do have that patient who wants to leave AMA. They can only be discharged to a psych facility and are presumed to legally have decision-making capacity, still refuse intervention, still refuse psych meds unless there's an emergency. So if someone's certified, the biggest thing is they can't go AMA because the security will get involved. Let's just do question. This is just basically saying that if someone's psychotic, they can have capacity. Functional, there's different areas of capacity. You want to think about cognition and the presence or absence of a specific condition. Obviously, if someone's has really bad depression and they're saying they want to starve themselves to death, they may not have decision-making capacity because their underlying condition isn't being treated. So do you guys have any questions for me? Yeah.
So say you are and you withdraw and
Hmm.
your medical hey, I can't restrain them before they're certified.
I would page psych because that's not true. You can, physicians can put in restraints orders. We have a thing in our call book on how to do it at Hines. You tell them, you sir are misinformed. Yeah. That's a good question. I think it's best to explain things in the most simple terms possible. I think we get used to just speaking the language of medicine, but it is like a different language to people who aren't in this environment. I think transparency is really important. And then just like sitting down and actually having a conversation and really listening to the person, as well as using like the most using simple language to describe things. You could use like visual aids, you could use a bunch of stuff to help clarify what exactly the procedure or treatment option is that you're proposing. Yes. Yeah. Oh, asymptomatic? Well, what's the decision we're trying to check? I mean, I'm sure people walk around making decisions with blood sugars of like 60 all the time. You know, like I think that it would depend on you would have to assess what the decision is, and then what's their understanding, what's their reasoning, what's their rationalization. Like I could have a brain tumor right now and I'm talking to you guys, like who knows? So I mean, I think that just because something might be festering under the surface doesn't disqualify you from having decision-making capacity. I hope I don't have a brain tumor. That would suck. Yeah. Uh-huh. No. No. What other stuff were they using? No. No, because it's a partial opiate agonist. So I mean, you do want to be careful. If they're the thing about like any kind of medication assisted treatment in substance use, if they're not ready to quit the coke in addition to the opiate, you know, they're probably not going to be good candidates for medication assisted therapy because their adherence isn't going to be good. And even Suboxone that can be prescribed 7 days at a time. Methadone, a lot of that is contingency. You have to go to the clinic every day. You have to take UDSs, breathalyzers. So no, someone lied to you too. There's a lot of lying going around in this hospital. Oh yeah, if they're hospitalized, I say make them comfortable. They're not going to get it at discharge. So I mean, like it with opiate withdrawal, unfortunately, you do want to do something like starting Suboxone if they're a good candidate. Otherwise, you do the comfort medications. It's callous sounding, but it won't kill the patient. Something like benzo or alcohol withdrawal can be fatal. So load them up with Ativan. 5, B52, man. Yeah. So Benadryl, Haldol 5, and Ativan 2. Yeah, it is. I mean, yeah, knock them out. They won't be difficult if they're asleep.
Thank you.
Thanks, guys.